I'm Miguel Villalona Calero. I am the Director of Medical Oncology for the Ohio State University Department of Internal Medicine and the Ohio State University Comprehensive Cancer Center. Maintenance really in lung cancer means when somebody gets a metastatic disease or a disease that is very, very advanced, and you give initial treatment, and then the treatment is able to produce a response in the tumor, so some shrinkage of the tumor, or is able to produce a stability of the tumor. So then the question is, for how long you continue? Shall you stop? Or should you continue with treatment, or actually to add something different to the treatment that you already gave to the patient? So again, these are not the patients that the tumor is growing after you gave the treatment, but the patients that the tumor is stabilized or shrank with the initial treatment. And traditionally, the definition of how long you treat the patients had been about 4 months, and that is based in some studies comparing 4 months versus 8 months of therapy showing no difference. So typically then what we did with patients is just to treat for those 4 months, maybe 6 months, and then stop and wait for the tumor to regrow. And then at the time that the tumor regrow, then you can introduce a second-line therapy. So now the question of the maintenance is now that some second-line therapies were found to be somewhat efficacious, like for example erlotinib that we mentioned before, a tyrosine kinase inhibitor, or pemetrexed or docetaxel, which are different chemotherapy agents, typically not used in the first line in these patients. The question is if you then give them to the patients after the initial treatment, if you will make the patients live longer as opposed to just waiting for the tumor to regrow and then treat. And the recent studies that you alluded to, they look at giving these agents early, and they call it maintenance. It is kind of a little bit of a misnomer because in the studies they did not compare early versus late. Right. So there was one study before that that was a study with docetaxel. And the study with docetaxel, they did look at early intervention versus late intervention. So they didn't call it maintenance, but it's the same thing. And they show no big difference in terms of survival. Now, the studies that were presented at the last ASCO used erlotinib and used pemetrexed. And what they did is they compare this a continuation or adding this therapy to patients that have a tumor stable or reduced after 4 cycles of initial therapy, and they compare to nothing. And they show that the patients that receive this additional treatment live longer in both cases, the erlotinib and in the pemetrexed. Now, this is substantial information, and partially this happens because these agents are active. They have some activity. So pemetrexed is a great drug, erlotinib is a great drug. They have activity in some patients, so they added something. But what is not clear yet is if early intervention is better than late intervention. So they did not really compare to continuing treatment or introducing that treatment versus just waiting until the tumor came in and then add it. That was something that doctors could do, if they wish, but in the places where these studies were conducted, these agents were not readily available, so a lot of patients did not get it. So therefore, it was not a direct comparison between early to late intervention. It is approved for pemetrexed. The FDA advisory board declined the approval for erlotinib, so it was not approved in the maintenance setting, but pemetrexed is approved, so you could use it if you wish. And what I do in particular is I use judgment, so I use it in a case-to-case basis. For example, a patient that came in with a disease that was producing a lot of symptoms, and I was able to, with initial therapy, to improve those symptoms, then I will be more likely to use it to keep this patient free of the symptoms that he will develop again when the tumor progresses, as opposed to somebody who didn't have symptoms at the beginning, and want to enjoy some quality of life. So having that break that between the first line therapy and the second line therapy may be warranted in those cases.